Hello, everyone. So this module, we are going to be going a little bit away from technically scanning something in ultrasound. We are going to be looking at something that a lot of people tend to overlook or they don't really take into consideration in this profession. This is going to be a very important topic that I'm going to be constantly coming back to throughout the entire duration of the program. This is something that you have to have a strong understanding of when you are a professional in this field if we want to be scanning for the next 10, 20, 30, 40 years of our lives. So ergonomics is a very important topic that is not talked about as much as it should be. So what is ergonomics? This is going to be defined as the science of fitting a workplace to the user's needs. Ergonomics aims to increase efficiency and productivity and reduce discomfort. So ergonomics is the broad general term. This isn't something that is just specific to ultrasound. This is something that should be applied to any type of job. How do we perform that job in a way that is efficient and is also not going to produce harm to our physical well-being? So the overall concept of improving ergonomics is to aim to increase productivity while decreasing injury. So this means that we have to be modifying how we complete certain tasks. We need to be doing our job and operating our equipment in a way that is not only beneficial for our patient and for the exam, but also in a way that is going to keep us safe and working in a healthy environment. So the history of ergonomics in ultrasound itself, this is going to be something that has changed drastically over the last 30, 40 years since ultrasound really came out. In 1980, we started to see a little bit of ultrasound-related pain and discomfort for the techs that were performing these exams. Now, if we remember back to one of those very early PowerPoints that we had, we saw the evolution of ultrasound equipment. And we saw that when it first came out, it was pretty much like operating, heavy duty machinery in a factory. It wasn't like the type of systems and transducers that we have today. So it was very new. It was really primitive. It was something that wasn't really aimed to keep the person performing the exam in mind. It was really coming out to see what can we do with this technology. So the technologists and the people performing these exams were really kind of an afterthought, or not even really a thought at all when it was first coming out. In 1985, we started to see ultrasound really kind of explode in the healthcare field. We started seeing it used more frequently. We were kind of sending everybody and their mother for an ultrasound. It was something that was like the hot new thing on the market. So a lot of these techs who were performing these exams were really starting to complain about physical discomfort from performing with these machines and this equipment. So we had a research study that was conducted. It was about 100 sonographers who had typically 5 to 10 years experience, but we did have some really kind of first generation techs who had been scanning for about 20 years at that point. So this was something that, again, was more the techs kind of performing the research of when ultrasound started to first come out. So the majority of these 100 sonographers were going to be people who were really kind of doing this once it kind of like took a hit in healthcare. So we were seeing a lot of techs who had that 5-10 year range of experience. They were complaining of stress and burnout, so they were really overworked and understaffed when ultrasound was becoming popular. They complained of visual problems. They were susceptible to a lot of infections because we didn't really have disinfecting protocols at that time. They were starting to have allergies. They were experiencing electric shock, and they were talking about muscle strains. That last one is really going to be what we're talking about a lot today. So this is when sonographer shoulder became widely known. So this research study was what was kind of drawing attention to the people actually performing these exams. And again, just another recap of kind of what those machines and what those pieces of equipment looked like when it was first coming out in the 1980s, late 1970s. So sonographer shoulder, this is something that if you talk to any tech, they are going to say that this is the biggest drawback of this profession. Our shoulder is our moneymaker. This is how we go to work. This is how we get our paycheck. This is something that we have to preserve. So this isn't just including our shoulder. This is including our entire scanning arm. So this is the elbow, the wrist, our fingers. We experience a lot of pain and strain. We get stiffness over time, and we can develop carpal tunnel in our wrists. This is mainly going to be caused by having to use heavy transducers and cables. Now, that's kind of the standard answer or the standard reasoning behind sonographer's shoulder, but in the practical world, in the clinical world, we see an increase in sonographer's shoulder with an increase in patient body habitus. So in our country specifically, we are seeing the general population become a little bit larger over time. The general body habitus has increased over time, and our equipment hasn't caught up to that. So as our patient body habitus is increasing, we have to apply more force with our scanning arm during those exams. And that's going to be a big contributing factor to sonographer's shoulder and a lot of these complaints that we're going to talk about today. It's really, really important for you guys to never sacrifice your physical health in order to obtain a pretty picture. We will learn the tips and the tricks to work with a patient who has a larger body habitus. We will learn when to say this is a limited exam. We will learn when to, stop and listen to our body, not at the expense of a nice picture. So OSHA is what is typically the organization that will oversee the standards in which we have to work. So they are going to be the ones who set kind of the general workplace practices. So this is basically saying, they set certain procedures and policies that you can't work under certain conditions and that your employer has to provide you with certain resources if you're performing X, Y, and Z type jobs. So OSHA stands for Occupational Safety and Health Administration. Every organization has to abide by OSHA if they are employing people. So this is going to be something that came up in the 1970s. Congress actually passed this act, and the purpose of this is to ensure that every working person in the nation has a safe and healthful working condition and working environment. So the employee, you are responsible for complying with all of the rules that OSHA sets. However, this is mainly targeting the employer. So this is saying that the employer has to provide you with these healthy working conditions. Your responsibility is to just not be reckless, right? We're not going to go into an ultrasound room and start doing cartwheels, and then when we fall and hit our neck, try to blame our employer, right? So this is a mutual understanding between employee and employer that you are going to be working in safe environments and that you are going to be a responsible employee with that protection. So what did the ultrasound world do in response to that research study, in response to OSHA regulations, in response to general complaints with this profession? So prior to 1980, we had really, really archaic machines. Again, I've said this a bunch of times already. It was like operating heavy equipment. So this was going to be really rapid decline of physical health for these people performing these exams. So with that research study, with the OSHA regulations, these manufacturers of the ultrasound machines started to say, okay, we can't just look at the technical advancements of the science. We have to look at the ergonomics behind it. We have to start caring about the people who are going to be using this equipment to advance this technology. So after 1980, these manufacturers really started to put more emphasis on that research. So we started to get a little bit more advanced. We started to see our machines move from these very archaic, what we call B mode scanners, where it took 3 minutes to produce one image, and it moved to more real-time, two-dimensional scanning, like what we're seeing right now in our facilities. With that advancement, we saw a rapid decline in sonographers' complaints, but it kind of leveled off after 10 years. So we started getting these initial advancements in the 1980s, and we saw some improvements with that. We weren't having as many people complaining of sonographer shoulder, but then about 10 years goes by and we start to see those complaints coming back in, right? We start to see a lot more complaints kind of trickling in. And again, this kind of moved into another wave of ultrasound. So about 1995, late 1990s, we were really seeing just the majority of techs complaining of physical issues. Same thing moving into the 2000s, 2010s, about 90% of us were complaining of some physical issue related to performing our job. This is when ultrasound exploded again. So back in the 1970s, 1980s, we were really kind of seeing, oh, okay, we can use sound waves to look at the body, right? And we kind of had some manufacturer advancements, but wasn't until those 1990s, 2000s, 2010s where we were really kind of overloaded with work. We started realizing that we could use ultrasound for not just babies, but to do procedures and to do breast imaging and to look at vascular, all the vessels in the body. So we really kind of got a lot of technical advancements right after that equipment redesign, that ultrasound redesign. And that was when we were putting more and more strain on our body. So yeah, the equipment got a little bit better, but now the healthcare community was expecting way more from us. We were going nonstop with patients. And the machines, okay, they were better, but they weren't perfect. So we went from the picture on the top left-hand side to the picture on the bottom right-hand side. And that picture on the bottom right, on the bottom left, looks a little bit better, but it's still not great. Look at that transducer. It's like a big cinder block. Look at that console panel. It's really wide and really broad. So it still wasn't perfect. So we were seeing a lot of injuries because we were overworked with the capabilities from ultrasound. So this is when our research kind of came back to some of those complaints. And this is where we're now in the world of WRMSDs. It stands for work-related musculoskeletal disorders. These are going to be defined by injuries that result in any type of restricted work from your physical limitations, days away from work, symptoms of musculoskeletal disorders that are going to last for 7 or more days, and anything that's requiring medical treatment beyond just first aid. So these are talking about more of those chronic injuries that we're experiencing over time because our muscles are just overworked. So WRMSDs in sonography, you can have these work-related musculoskeletal disorders in any profession that you do. Construction workers, firefighters, EMTs, they all experience different types of WRMSDs. So what do we experience in ultrasound besides sonographer's shoulder? And what does sonographer's shoulder really mean? What does that actually do to our body? So this slide, for some reason, did not come over onto Collaborate how I wanted it to. So just bear with me and refer back to your PowerPoint in the module itself. But these are going to be caused by aggravated workplace activities. So aggravated means that we're doing a repetitive kind of bothersome movement again and again and again and again. So we're aggravating these muscles, these tendons, these joints that we're frequently using. And that constant kind of wear and tear is going to cause pain, inflammation, swelling. We're going to have long-term deterioration of our muscles and our tendons, and that can eventually lead to degeneration. So degeneration is talking about when something kind of just eventually dies off because it's not being supported the way that it should. So our muscles and our joints, if we are experiencing that deterioration or degeneration, are going to become further compromised once our supportive structures are weakened. So it kind of starts with some tendons, kind of starts with some ligaments, and then once those are bothered, then it moves into the muscles, then it moves into the joints, and it's an overall large problem in that targeted area. So WRMSDs in ultrasound are going to be the main reason for leaves of absence among healthcare professionals. So we see about more than 80% of sonographers right now complaining of some form of WRMSDs. So it's a lot, and it's pretty much every tech that you are going to come in contact with. Now, there are some risk factors that put us in a higher category for developing these musculoskeletal disorders, and these are all things that we can adjust. These are all things that are preventative. So awkward posture, forceful exertion, prolonged static posture where you're kind of just standing in the same position or sitting in the same position, repetitive motions, pinch gripping on that transducer, and extreme environmental conditions. So don't blame me, but our room here at the school that we scan in would not pass OSHA inspection because it gets too hot. You can't be scanning in a room that is too hot. You can't be scanning in a room that's too cold. You can't have a humidity level above a certain percentage, and you shouldn't be exposed to mechanical vibrations. So all of these things, if you're in a hot room, it's humid, there are vibrations, those are all going to have extrinsic factors on your overall physical health of those tendons, joints, muscles. So let's talk about these a little bit further. What is awkward posture? What is that going to do for us? It's going to cause an imbalance between our muscles that are going to help move and stabilize us in a way that is beneficial. So when we have awkward posture, we kind of get in that habit of just reverting back to that awkward posture. It's going to make our body off balance. If you're constantly leaning towards one side, if you're constantly hunched over, that's going to have an effect on those muscles that are affected by those movements. Repetitive head and neck rotation, that's a big one for us. So we constantly are looking at the screen, back to our patient, back to the screen, back to our patient. This is going to cause one set of our muscles to be stronger and therefore shorter, and the opposite muscles are going to become weaker and longer. So if you think about what that means, we have our patient on our right hand side. So if you are sitting straight and you turn your head to the right to look at your patient, the muscles on the left side of your neck become stretched, and with that prolonged stretching are going to become weaker. The muscles on the right side of your neck, they're kind of cramped up to your shoulder, right? So they become a little bit stronger because we're not putting force on them, and they get shorter over time. So that's going to give us that one-sided neck and shoulder pain. Asymmetric forces, this is going to cause spinal misalignment. So this means maybe if we stand to scan, we put one foot up on the machine. Well, you don't want to do that because it's going to put more weight and more force on one hip versus the other, and on one foot versus the other. So you want to make sure that gravity, that all of your forces are aligned and evenly distributed so that it's not going to have an effect on our large joints, our ankles, our knees, our hips, our spine, our neck. Prolonged static posture, like we said, we're in the same position for a long period of time. It's going to cause compression forces on our spine. So typically, if you're standing in the same position and you're not frequently adjusting yourself, or sitting in the same position and you're not frequently adjusting yourself, those vertebrae in your spine are going to become accustomed to that pressure, and they're going to compress over time. So these work-related musculoskeletal disorders can also cause nerve entrapment syndromes, and this means that when we have muscles that are bigger than they should be, they are going to compress on the adjacent nerve and cause nerve damage and problems with what that nerve is supplying down the road. So some common injuries that we've probably heard of before, but we are a little bit more prone to as sonographers: tendinitis and tenosynovitis. This is going to be talking about the inflammation of the tendon and or the tendon sheath, and these typically will occur together. Carpal tunnel, this is when we have entrapment of that median nerve, so that main nerve that runs through the carpal bones of our wrist. It's going to be caused by repeated flexion and extension of our wrist while we're scanning. Another type of nerve entrapment syndrome is going to be thoracic outlet syndrome. So this is going to be at different levels of our thoracic cage, and it can run from our collarbone, so our clavicle, all the way down the border of our ribs. So as we're constantly moving that right arm away from us, towards us, away from us, towards us, over time, those shoulder muscles are going to impinge upon the nerve that runs down our thoracic cage. So we're going to experience some symptoms associated with that. Trigger finger, this is known as the inflammation and swelling of the tendon sheath that's going to surround the tendon and restrict motion of the finger. We typically will see this in our pointer finger of our scanning hand, and sometimes in our pointer finger of our opposite hand if we tend to annotate and use our knobology with only one finger. Bursitis is going to be the inflammation of the shoulder space. Again, pretty straightforward, caused by repetitive motion. Rotator cuff injuries, repetitive motions, that's going to kind of over time wear down the rotator cuff muscle tendons. Typically have 4 major muscles in our rotator cuff of our shoulder. This is going to be caused by just aging and that repetitive abduction of the arm. So again, moving that shoulder further away from our body, rather that elbow and that arm away from our body. And spinal degeneration, this is going to be when our vertebrae and our spine just degenerate over time. It's going to be caused by excessive bending, twisting, and improper seated posture. So again, those asymmetric forces working against our spine. So what have manufacturers done recently to address this? Well, we saw a redesign back in the 1980s, 1990s, but what did we see after that? How did we go from those slightly more modern scanners to what we have now. So this is something that our manufacturers now in the modern world really are taking into consideration, because now it's a competitive market. So equipment, there are a lot of different manufacturers, there's a lot of different products out there. So manufacturers really are trying to sell this to the staff. They're trying to sell their equipment, sell the machine to their staff in order to make their lives easier. So they're taking us into consideration now, which is lovely. So our machines have significantly gotten much more advanced since that 1980, 1990 redesign. And they're still adjusting as we progress. So now our modern machines are going to have brakes, adjustable control panel height, adjustable height, swivel, and tilt of the monitor and display screen itself, easily accessible controls that are nice and close to where we would be able to reach them, transducers that are a little bit more narrow so that we can hold them a little bit more naturally, lightweight, thin, flexible transducer cords, and some cord hooks that we can drape the transducer cord on to relieve some of that gravitational pressure while we're scanning. So the exam table and chair, so in addition to the machine and transducer itself, we have to take into consideration the other equipment that we use in the room. So the exam table and chair, these should both be highly adjustable. So we need to see brakes, at least 2 forms of safety locks on an exam table, and we should see brakes on an exam chair as well. Electronically adjustable height for an exam table. We want to be able to put that table in a Trendelenburg, reverse Trendelenburg, or any sort of degree of inclination for our patients. They should also have stirrups for gynecologic exams, and they should have a drop-down compartment for those gynecologic exams, but also for some vascular and echo procedures. The chair itself, like we said, should have brakes on it, but we're also going to see them have wheels, adjustable height with flexion and extension options. They should be very narrow so that we have less distance between us and the patient on the exam table. And if we have the opportunity to use an ergonomic chair, we should. So if we look at the pictures on the right-hand side, that exam chair all the way to the right, the orange one, that is how we should be utilizing ergonomic chairs. You are supposed to sit in them backwards so that you can rest your elbows and your forearms on that pad, and you keep all of your angles at a 90-degree or less position. So it's very awkward at first, it's very strange at first, but they do provide a lot of spinal support, abdominal support, and they keep everything nice and straight. So it's something that we should be utilizing if we do see these chairs in clinic. Sometimes we'll see them look a little bit more like the picture in the middle, where again you can sit reverse in the chair and you rest your arms on these little pads, and you can lean forward with your chest and abdomen on that pad there. So proper scanning techniques. We are responsible for our own health. This is something that we have to practice the right habits in order to preserve our body. So this requires patience, constant correction, constant guidance, and just practice, practice, practice. It's common for healthy scanning to feel unnatural, and that's why when you guys are first starting out and you're holding the transducer, I'm looking at how you're holding it, and when I adjust your hand into a way that is ergonomically safe, it feels weird for you guys, and that's okay, that's normal. It's important to actively work on these skills so that we can build a healthy routine and habit, and like we said earlier, we never want to sacrifice our body or our comfort for just a pretty picture. We're going to learn the tips and the tricks throughout the program to help us obtain acceptable, high-quality images. So moving into some scanning techniques here, how we grip the transducer is really going to set us up for either success or failure. So we want to make sure that we're holding it in a natural fan position. We want to be using mild pressure. We want to use enough gel for an exam, but we don't want the patient to be bathing in gel. When we use too much gel, it makes everything too slippery. So even your hand can slip off the transducer. So you want to make sure that your hand is nice and dry from gel, but you have enough gel on the patient to easily glide over their anatomy. You also want to make sure that your gloves fit properly. You don't want gloves that are too tight, and you don't want gloves that are too big, because that's all going to either put too much force on your hand or too much pressure on your hand. You want to be focusing on using more of the palm of your hand and less of your fingers. Your fingers should be there to help guide you, but they shouldn't be there to help stabilize you. So you want to use the palm of your hand, the force of your hand, to be able to provide stability. You also want to make sure that you are using the patient's anatomy to give yourself forearm support. So don't be afraid to rest your arm on the table, on the patient, or put a pillow or a towel under there and just support your forearm so that it has something to rest on. So these pictures here, this picture is a big no, and this picture is a big no. So these are two extreme variations of each other. We want to be able to have our hand basically touching the patient. Look how this picture on the top right, they have their pinky and their ring finger kind of fanned out onto the patient's anatomy, and they're using the curve of their first finger and their thumb to really kind of absorb a lot of that pressure. They're using more of their palm to provide that stability, and they're using more of their fingers to provide kind of guidance and support. Same thing with the bottom picture. This one's not as great as the top picture, but we're still holding the transducer nice and low towards the surface of it. We're using our fingers for fan support, but I would just want to see that transducer be a little bit more in the curve of that thumb with the palm. Transducer cable management. So we want to make sure that our cords are not creating any extra pressure or force for us, and that we get them out of the way prior to scanning. So naturally, we are going to experience gravity on the cord. So we need to make sure that we can hook the cord up out of the way, or some people you'll see are using cord braces where they can actually wear this brace on their forearm and it kind of holds the cord up along their forearm. All that does is it redistributes that gravitational force. So I don't technically prefer these, but you may see some techs using these. Cord hooks are what we should be using, located typically under the console of the machine, and you can use those to make sure that you get the cord up out of the way. And one thing, we should never, ever be draping the cord around our neck. Not only is it an ergonomic issue, it's putting gravitational pressure on your neck, but it's also a infection control issue. You are putting a dirty cord from the hospital really close to your face, and it's also an electrical issue. So if that cord and that transducer were to ever short circuit, it would be directly touching your neck with your major blood vessels in your brain. So we want to make sure that we're never putting that cord over our shoulder or over our neck. So neck and trunk twisting. So this is going to be something that can be a little bit difficult for us when we're trying to be creative with our scanning. So we always want to make sure that our machine is directly in front of us, our screen is directly in front of us, and our patient is directly on our side. We want to make sure that we have our hips facing our machine and our patient is perpendicular to our right side. So we have to decrease the amount of distance between the machine, us, and the patient. The machine should be as close to the patient as possible and as close to you as possible. You want that monitor and console directly in front of you, not on any angle. When we have any sort of twisting of the neck, it's putting pressure on our vertebrae and our spine, and it's going to lead to degeneration, strain, and pain of that spine. Now, our trunk, so our chest and our abdomen, when we're standing, we want to make sure that we're not leaning, that we don't have one foot up, that we're not kind of crossing our legs. You want to make sure that your feet are evenly distributed, you have weight balanced on both feet, and they are going to be shoulder width apart. We're not leaning towards the side, we're standing nice and straight. If we're sitting, same concept applies. You don't want to have your legs crossed, your ankles crossed, you don't want to be leaning to one side, you don't want to be slouching forward, you want to be sitting upright, kind of engaging your abdominal muscles so that they can help support your trunk. So here we have two awful examples of neck twisting and trunk twisting and cord management. And these are actually two of my students from the very first group that I had when I started here, my lovely volunteers. So picture on the left-hand side, actually both of these pictures, I'd like you to pause the recording and just see if you can find what is wrong with each of these in particular. So hopefully you were able to pinpoint some things that were wrong with these. So if we go picture by picture on the left-hand side, look at how, now this tech is scanning on the opposite side, which is fine for this example, but look how far away the machine is from the patient. Look how far away the patient is from the tech. Look how low the machine is. He has to look all the way down and over to the side. His arm is abducted really far away from his body, and the cord is kind of just dragging from the patient to the machine. It's just not great, right? There's so many things that we can fix with that. Picture on the right hand side, it's a little less obvious because the machine seems to be at a proper height for her, but she has the cord draped around her neck. She has this really strong grip with the transducer that's not really going to allow her flexibility. She has trunk twisting. Her neck is twisted a little bit towards the side. The patient is kind of close to her, but look at her feet. Look at all that weight distribution, right? So she's going to be putting a lot of extra force on this hip, while this hip is going to be not experiencing any weight. Same thing with this ankle and this knee, putting all of her weight on that side of her body. Now, these are a little bit better. So here with our seating example on the left-hand side, machine is nice and straight. She's close to the patient. The machine is close to the patient. Her feet are evenly distributed. This is an ergonomic chair, so she could technically have that turned around to be sitting in it reverse, but that's okay. She has cord management options going on. She's wearing a cord brace. She has a more relaxed grip on the transducer, and everything is aligning nice and on a 90-degree angle with everything. Now our standing example here, so now she has adjusted her posture. She has her feet flat on the ground. Her hips are nice and straight. Her neck is straight right to the console. Her arm is close by her side. She has the cord draped on the machine, and she relaxed her grip a little bit, but we could still probably work on that. So our scanning arm abduction, this is going to be the main reason why we experience shoulder pain, and we want to keep it as close as possible to our sides. So we want abduction to be less than 30 degrees. This means that we have to be adjusting the exam table, the scanning height, everything constantly depending on our patient and depending on us individually. So we want to make sure that we are adjusting this so that our arm is going to be closer to our body rather than further away. You want the patient to be as close to you as possible with your side to hip touching if possible. You also want your patient to be safely positioned on the edge of the table. So although we do want to pull them over towards us, make sure that they're not going to fall off. You want to make sure that if you are a shorter tech, that you are most likely going to have to be standing for a lot of your scanning. And if you are a taller tech, you may have to sit. So this is all something that we will have to figure out on a case-by-case basis with everyone individually. And you also just, kind of experiment with what feels right and what seems right ergonomically for certain exams. So you may stand for certain exams, you may sit for certain exams. You have to figure out what works best for you so that you're practicing your proper ergonomics. Reaching is another really big one, and this is not just towards the patient, but this is also towards our machine. So we want to make sure that we are not reaching for anything. We're not reaching to get to the patient. We're not reaching to get to the buttons or controls while we're scanning. So we want to make sure that, again, everything is as close to us as possible. Everything is aligned directly in front of us, and the patient is directly on our side, so that we're staying in a neutral position. And when we're not using the controls, when we're not actively setting up our knobology, we want to bring our arm back down into our lap or by our side if we're standing. So we don't want to extend our arm unnecessarily. Let that arm rest whenever possible. So here we have just all around awful ergonomics. Same thing, I'd like you to take a second to kind of just see how many issues you can find with each of these pictures. So you can go ahead and pause here. And hopefully you actually did. So top left-hand picture, look at how far she is reaching with that transducer up towards the patient's shoulder. So why is our patient sitting, right? How come she couldn't lay down? Why is the tech sitting that low? Why is the machine that far away from her? Why is she reaching with that computer hand unnecessarily? She's looking up at the screen. It's just overall not good. Picture on the top right-hand side, look how far away the patient is from the tech. Look how high up that exam table is. That machine is not nice and straight in front of her. Bottom left-hand picture, same thing. Machine's all the way off to the side on an angle. He's reaching with that left hand unnecessarily to point at the screen. His right hand is really abducted far away from his body. The patient should be higher up on the stretcher so that everything can be closer to him while he's scanning. And picture on the bottom right-hand side, she's scanning with the opposite arm. So she is reaching over her own body. Her neck is twisting all the way in the opposite direction. Her hips are twisted towards the patient. The machine's really far away from her. She doesn't really have a great grip on the transducer, and the cord is resting on her forearm. So we definitely don't want any of these examples. So what are some scanning tips and tricks that we should be implementing now? So you have to, especially when you're first starting out, ask for help. If something doesn't seem right, or you're struggling, ask for help, ask for suggestions, and also ask for help in terms of actually scanning an exam. You can have a coworker, we're typically doing, one-on-one cases with our patients, right? We're the tech and we have a patient, but there are certain scenarios where if we're in the ICU or we're doing a portable, which we'll talk about in a second, we need another tech there to physically help us operate our exam and our equipment. So we have to ask for help. We have to have good communication skills for that. We have to be creative with our patient positioning. So we're not just going to have our patient lay down on the table, right? What if that doesn't work for us? What if our patient can't get on the table? What if we have to scan them in a wheelchair? What are we going to do? Just say no because we can't? No, we have to learn how to be creative with what pictures we need to get, how we can get them, and how our patient can accommodate that. Have our patient move on their own if possible, always. Always have your patient do the movement for themselves if they can. Now, again, if our patient is intubated and unconscious, they are obviously not going to be able to move for us. But if our patient is capable, coherent, they understand what we're saying, or we can show them how to move, let's do it, right? Why are we going to put extra force on our body when we don't need to? And use accessories if available. So again, you can use cord braces if you would prefer, but it's not really solving the problem of gravitational force. It's really kind of just redistributing gravitational force from your shoulder down to your forearm. We do have some positioning sponges that we can use depending on how our patient should be positioned or should rotate during our exam. And then if you look at this picture here, they're tag teaming that exam. So you have one tech who's doing the physical scanning, and the other tech can't get to that machine in a way that's ergonomically safe. So she got somebody else to help her operate that equipment in that part of the machine. So portable scanning, this is our absolute nightmare in ultrasound. This is going to be something that is really, really challenging for us because it's just, there's so much going on. So this is something that we do if our patient is unable to be transported to the ultrasound department. So we're typically going up to the patient's room, the ER, the OR. We're going to the patient to do their exam. We're taking the machine with us. Now, the problem with doing a lot of these portables is that it is an ergonomic nightmare. So we kind of jump forward here a little bit, but some issues with portable scanning. We don't have space. There's a ton of tubes, lines, cords, wires, catheters, all this stuff coming out of these patients, and we can't touch any of it. Our patients are typically not going to be able to move, and they're not going to be able to be positioned in the positions that we're used to having them scanned in. We have oversized beds, so they're not coming down on an exam table or a stretcher. They're in an actual hospital bed, so they're going to be inherently further away from us. These rooms tend to not have light dimmers, so we have to scan in a room that's very bright. And some solutions to this is that we always have to talk to the staff in that unit. So we're always asking for help. We're asking a coworker from our department to come up with us, or we're asking help from the department itself. We're asking a nurse, a CNA, anyone who can come in and help us move some things around or rotate the patient. We never want to go into a patient's room without communicating to that desk in the unit that we are there and that we are going to be going into that exam room. We don't know what else that patient may have going on, and it's a great way for us to say, hey, can someone come help me with this patient? I need help rotating them, or I need to move this wire out of the way. Can you move it for me? The worst thing that can happen is that you unplug something that is part of that patient's life support. So just don't even take that risk. Make sure you're going in, you're talking to the front desk of that unit, you're getting a nurse's help, and that you're communicating effectively. You also want to make sure that you rotate sonographers. So if you're in a hospital setting, portables are done pretty much all day, every day. It's not something that one technologist should be doing all the time, or even for the full day. This is something that you have to take turns with doing. These inherently are going to be putting force on your body. No matter what we do, no matter the tips and the tricks and the helpful things, it's automatically going to be an ergonomic issue. So it's not fair for one tech to be doing these portable exams all day and just inherently breaking down their body over time. So sometimes they'll do morning portables, right? You'll have one tech who does the portables in the morning. Maybe they do 4, 5, 6 of them. And then in the afternoon, they're back in the department doing regular exams. Maybe it's 2 techs that go and they rotate every other portable. You shouldn't be doing all of these on your own every day. It's not fair. Sometimes we do see facilities that will try to pawn these off onto new employees or new grads because they think, oh, they're young, they can go do it, or oh, they're new, they need to earn, they need to earn their respect in the department. It's absolutely never an excuse. You should always be standing up for yourself in that scenario, always be rotating. And that also means that you need to be going and doing these portables as well. So we're not just having the tech who's been there for 30 years just going and doing portables because, oh, that's just her, that's what she does. No, take some of that off her plate as well. You also have to be creative, like we had mentioned, and you have to make sure that you're taking your time. There's no rush with these. You do what you can, you get up there as fast as you can, but you do what you can. You don't want to be rushing and, like I said, unplugging some kind of equipment or pulling out a tube or pulling out a line that could be part of that patient's life support. So take your time, pay attention, do what you can, and problem solve. So here is what, we would like a patient's hospital room to look like. It's nice and spacious, right? Not really much going on. Adjustable bed. Seems quiet. This is what we're dealing with. So this is what portables look like. They're intimidating. They're really sad. And it's tough. It's a tough part of our job. It is a rewarding part of our job. I do encourage every new grad to take their first job in a hospital setting because this will just inherently improve your skills rapidly. You learn how to problem solve, you learn how to be creative, you learn how to communicate, you learn more about the healthcare environment than you would if you were in an outpatient facility. So this is something that you are going to see in clinic, you are going to be exposed to in clinic, you are going to be going on portables with techs at clinic, and you're going to see how they take them on a very individual case-by-case basis, how they communicate with the floor staff, how they move the equipment, they know what they can move, they know what they can't move, they ask for help, and they do what they can. So it's something that we will be exposed to. It can be overwhelming. We do see patients who are in long-term comas after horrible accidents, really severe illnesses, on kind of like last line life support measures. So it can be really, really tough. So physically, we want to make sure that we are prioritizing exercise in whatever way that we possibly can. And this doesn't mean you have to go to the gym and lift weights 3 times a day. This just means that this should be something that you prioritize in your general routine life. So regular exercise is going to help us to maintain our muscle integrity and tendon integrity. So this is something that will help us over time. It's going to help strengthen and stretch those frequently used body parts, especially our arms. So it's beneficial if you were to kind of pick up just some light weightlifting routines that you can maybe do at home when you get home from clinical or in the morning, just to kind of slowly build up that strength in your upper body over time. It's not going to do any harm, and it's going to preserve you for a long period. And the mental aspect of all of this. So this also goes into our, work-related issues that we have to be aware of. So we have a very high stress career, more so than any other imaging modality. We are independently responsible for our patients. If we miss something, they're not getting a diagnosis. Okay, and that's big, right? So the radiologist, the medical team, they rely on us a little bit more than they do with other modalities. We have to have an insane depth of knowledge. I mean, we just have to know a lot about everything. We have to have critical thinking skills. So when we're up in those portables, what do we do? Or if we're going to the ER, we have a patient from the ER, what do we do? How do we call the code? All of these things can wear us down over time. We have to have strong problem-solving skills, extensive patient care, and again, we're that frontline diagnosis. So there's a lot of weight on our shoulders, and we certainly don't get the recognition that we should in the healthcare community. So it's something that I like to really highlight to you guys, that when you start clinical, it's fun and exciting, and you get to showcase what you've learned so far, but it's also very overwhelming. It's very stressful. You are going to be thrown for a loop more times than not, especially when you're first starting, and you have to just absorb it all. You have to take everything in. You have to learn from everybody as much as possible, and you also have to learn what is good for you. You have to be able to go home at the end of that shift and say, I'm going to leave that at work. I'm going to leave that at clinical. You can't bring it into the next day. The other thing that we have to kind of balance is that we go from extreme highs to extreme lows. Our first patient of the day could be an IVF patient who has been trying to get pregnant for years and years, and then we finally see a heartbeat, right? Like, that's awesome. That's so exciting. Like, we want to enjoy that with our patient. And then our next patient, we could find metastatic cancer all over somebody's abdomen. So we have to learn how to balance all of those ranges of emotions and scenarios. And that, takes a toll on us over time. So we get stressed out, we get anxiety, we see a lot of techs suffering from depression, fatigue. They start to resent the profession because it's a lot that's asked out of us, and sometimes we don't get the recognition that we need. But that's something that we have to work on our own. We have to find things that make us happy, that help us relax. We have to implement healthy habits in our outside life so that we can bring that positivity to work, and we can bring that normal, level-headed approach to our normal work day. You have to prioritize sleep. That's a big thing that I see with you guys as students, is that you're in college and it's fun, right? You want to do stuff on the weekend, but you're in a healthcare program right now. You have to prioritize your sleep. You got to get up and go to clinical. You think the techs aren't going to be able to tell if you were up all night long? They'll know, and they'll send you home because you're not going to be able to focus on those patients. You also have to have time management skills. Again, you want to go out on the weekend, but you got a big exam on Monday. Should you do it? Probably not, right? So there are a lot of things that we're going to miss out on from being a healthcare professional, but there are a lot of things that you can still do, you can still enjoy, you should still do for yourself in order to have that time management skill, that work-life balance. You have to look at, what are your responsibilities? What do you enjoy doing? Where does that all fit into your schedule? So it's an overwhelming thing. It's an overwhelming program. It's an overwhelming profession, but it is so, so rewarding. And it is something that you should still have a passion for 20, 30 years down the road. So any questions about particularly any of the ergonomic topics on here, please feel free to reach out to me. Again, these are all things that I'm going to start implementing and adjusting while you're scanning in lab. We've been kind of lax with it up until this point, but I am going to start to critique and use some of these terms. So when I do tell you to adjust your neck twisting, you should know what that means. If I tell you to look at your cord management, you should also know what that means. So we're going to start to add these things in as well with lab. So Feel free to email any questions.